Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. In this election year, a lot of important healthcare issues are at stake. In today's episode, we'll explore the complex issues impacting rheumatology in the legislative and policy arenas, from proposed Medicare cuts to physician payments, to the role of pharmacy benefit managers, and how telemedicine reimbursement might change in the future. We'll also discuss what rheumatologists, patients, and the healthcare community can do to advocate for better outcomes. Joining me to discuss the issues that matter most to patients and their rheumatologists are two experts at the forefront of ACR's advocacy efforts, and they're also veterans of the ACR On Air podcast. Our first guest is Dr. Christina Downey, Chair of the Government Affairs Committee and Associate Professor of Medicine and the Division Director of Rheumatology at Loma Linda University Medical Center. Our second guest is Lennie McDaniel, the head of ACR's DC office and the Director of Congressional Affairs. Enjoy. Lennie and Christina, welcome back.
Hi, thanks for having us.
You guys are both pros being on this podcast before. I wanted to talk a little bit about what are some of the issues that the ACR is working on for the rest of this Congress. What are the topics that the ACR thinks are important?
The topics that we're working on are the same that we've been working on, and they're driven by our health policy statements. What's changed, this being a lame duck Congress, is that we are hoping to get some bills passed through that may be a little bit more challenging to get passed through when the changing of the guard takes place next year.
Yeah, it's going to be really interesting, and we'll talk about the new administration towards the end of this episode. So what are those topics, and what are some of those policies that you guys are working on?
Sure. So the 2025 Medicare physician fee schedule final rule just came out of CMS, and it's proposing a 2.83% cut to physicians across the board. And obviously, with the pressures of inflation and other factors, that isn't great for our members, but especially on top of, for the past 30 years, we've been looking at cuts nearly every year. So we can't keep doing this. This year, we've got some momentum behind some changes. We've been lobbying for a long-term statutory update that would link the physician fee schedule to an inflationary update. Every other Medicare provider, hospitals, outpatient clinics, et cetera, have inflationary updates. Their fee schedules are linked to a thing called the Medicare Economic Index, which is updated for inflation. Only physician reimbursements aren't linked to that economic index. So there's a bill out there called HR 2474 that we took to the Hill in May and have a lot of traction behind. Unfortunately, obviously, that's a very expensive endeavor long term. But we have some advocates on the Hill who have introduced a 1-year solution that would do a 1-year inflationary update to zero out the 2.83% cut and do kind of a 1-year inflationary update for physicians that we think is probably going to end up being the compromise. Obviously, we're still lobbying for a longer term inflationary update, but we need to see a solution before December 31st, which is when we would see that 2.83% cut.
Wow.
So we're hoping for something that avoids that cut and sees something on top of that gives our physicians some relief from the pressures of inflation that they've seen all year and will see again next year.
Is there a reasoning behind the cuts to Medicare reimbursement for physician payments? Like, who comes up with that idea that, oh yeah, let's just cut physician salaries even more?
Yes. So a long time ago, a well-meaning piece of policy put a balanced budget requirement on the Medicare physician fee schedule. So anytime you readjust any portion of Medicare reimbursement, you have to take that money from elsewhere in Medicare reimbursement. So if you decide that any particular service under Medicare or surgery under Medicare, it has been undervalued and it's going to be reimbursed slightly higher next year. The cost of that has to then be deducted from someone else's Medicare pay for the next year.
Ah,
So because of that, that's another long-term change that we've been lobbying for a long time, is a repeal of that balanced budget requirement, or at the very least an update of the cap. Right now, the cap for the change is $20 million, which at the time seemed reasonable, but we need to update that for inflation as well. Updating that for inflation would be about $55 million. So
mm,
that would just mean that now, if we get that update, that cut would not be triggered until that change amounts to at least $55 million, which would be really, really helpful moving forward. But yeah, with all of the change going on in DC, we would love to see a new crop of legislators maybe come in with fresh eyes and understand that the system that we're operating under, you can't have these kinds of restrictions and expect providers to be able to provide care, quality, expansive care, when you can't be reimbursed what it costs to provide it. And with these restrictions, the way in place for as long as they have been at this point, it costs more to provide the care than physicians are being reimbursed. And that we're seeing that across the board. That's not a rheumatology problem. That is a Medicare provider problem. So we are in a lot of coalitions that are fighting this fight, but it is with every one of these it's seemingly tiny, 2.83%, but with every year that happens, it gets worse. And at this point, it's a crisis.
yeah. And do you know, certainly, the US spends more on healthcare per capita than, I think every other country. To what extent are physician payments the problem, or are there other areas of the healthcare system that are more costly than the physician payments?
There So, yeah, physician payments are not what is driving bad outcomes and overspending in the healthcare system. So, there is almost like a shadow organization called primary or pharmacy benefit managers, or PBMs. These are third party dealers. They do not actually provide any other services aside from negotiating rebates and charging fees for their services. If we were to eliminate the pharmacy benefit managers from the equation entirely, we would have a lot of money to play with to try to get folks healthier, to try to keep practices open. I have a colleague who has had to shutter her business, and she was the only rheumatologist in her area. And she cited the decline in reimbursements and the inability to keep herself solvent as the reason for why she had to shutter her practice. And she wrote letters to her patients urging them to reach out to their representatives and let them know that they just lost their doctor because their doctor couldn't afford to keep the doors open. So imagine how many more of these practices that we could help keep in our communities if we didn't have PBMs taking a vacuum and sucking all of this cash out of the system. And Lennie can give you more particulars on the numbers because the number of billions that they make every year are escaping me.
So I think it's pretty widely known that there's only two ways to make money in the healthcare system at this point, and it's to be an insurance company or to be a pharmacy benefit manager. And at this point, the insurance companies have purchased the pharmacy benefit managers, and they are taking so much money out of the system, and there isn't money left to pay the institutions that are providing care, the institutions that are employing physicians, and physicians that own their own practices are at the lowest of the totem pole. But the estimated amount that PBMs, so the global pharmacy benefit manager market is estimated to be $589 billion
Oh
for
my goodness.
2024. And as Christina noted, they are not making drugs. They are not selling them to patients. They sell nothing. They make nothing. All they do is broker deals between insurance companies and pharmacies. So this is literally a middleman that does nothing but negotiate formularies and So they're purposeless. They just suck money out of the system.
Right. They get a cut for those negotiations, right?
Yeah. And this is an area where the new administration has signaled some agreement with the healthcare industry, with us on their willingness to seek some reform in this area. And we're really excited about that because this is an area where, pharma agrees with us, specialty medicine agrees with us, AMA is with us on this.
Hmm.
The Hill has really signaled some willingness to work on legislation on this. There's been legislation introduced in this Congress to reform PBMs. I think this is an area where everybody can see that is too much money to be taken out of the system, a system that is not working efficiently enough and not serving patients well enough. It cannot survive nearly $600 billion being taken out by someone who's not providing service.
Right.
So it's got to be addressed for us to go back to even kind of being an efficient system, but we need that $600 billion for sure.
Yeah, I
And
mean, certainly if physicians aren't getting adequately reimbursed, like Christina mentioned, there's going to be fewer physicians that want to retire, less people that want to become physicians because of its less lucrative profession. So patients are ultimately going to suffer because of it. And how important are Medicare reimbursements? Does that just apply to people on Medicare services? Or do other insurance companies look at the Medicare reimbursement to determine their payment systems as well?
Yeah, a lot of commercial payers are based as a percentage of Medicare. So we do see some declines in the overall reimbursement rates. And so it's harmful in that way as well. It kind of trickles down. The other way, going back to the PBMs, the other way that we've seen that PBMs contribute to worse outcomes in the United States is formularies are getting more and more restrictive and more prescriptive. So having to keep people on drug that's not working for 3 months, not being able to continue patients who have been stable for a year or longer on their current therapy because a pharmacy benefit manager executive who sits in an office who've never seen a patient or treated anything in their life gets to tell me that I can't give my patient what has been working for them. I am certain that contributes to increased healthcare costs and worse outcomes. So the PBMs really have to go for many, many reasons.
That's such a good point. I recently had a complex patient. She had multiple sclerosis and inflammatory arthritis, and she was on B-cell depleting therapy for her MS. And I wanted to get a certain type of a biologic for her inflammatory arthritis, but it just wasn't covered by her insurance company. And they're like, oh, you should try TNF inhibitors. I'm like, not a good idea on patients with MS. So you're absolutely right. They have no understanding of medicine or healthcare. It's such a pity. How did PBMs get involved and become so omnipresent in the US healthcare system?
So I'm going to quote what I was taught at our May advocacy meeting by senior advocates who have been in this game a lot longer than I have been. And from what I remember, the PBMs initially started out as a very small service as a way to help with antibiotics and hooking up, the antibiotics with the pharmacies who needed them. And then somewhere along the line learned that there's a lot of money to be made. And then they've sort of reached their tentacles into every single corner of the care system.
Yep. Where a consultant can find a business, they will not be stopped.
Amazing. So certainly, yeah, that has a lot to do with Medicare reimbursement, because if there's a certain pot of money that needs to be distributed and a whole bunch of it goes to PBMs, there's going to be less of them to go to physicians and all the other services that patients actually need. Sounds like an important issue.
And back to your question about Medicare reimbursement. While Medicare reimbursement impacts reimbursement for, as Christina noted, for private payers, it also dictates Medicaid reimbursement. They largely base Medicaid reimbursements off of Medicare, so it impacts the entire system. It is also important to point out that rheumatologists as a specialty interact with Medicare system more so than almost any other specialty, just because of the percentage of our patients that are Medicare patients. And so our specialty are really on the front lines of we're a real bellwether of the Medicare system and how the reimbursement is working and the impact of changes to Medicare and the reimbursements. And the first to kind of to suffer when the changes are too big and hit too hard. So when we talk about the impact of changes to the Medicare physician fee schedule, we are always the first to see them, feel them. And because we're such a small specialty, we have to really fight to make sure that people understand the impact of those changes. Because by the time it hits everybody else, the impact on the workforce and the drive and the impact on consideration for people who are considering joining the profession, we're already seeing the impact for generations to come and for future patients who are going to have to wait a long time to get the healthcare that they need.
And I did not know until this last May when we were on the Hill advocating. John, do you know when the budget neutrality trigger was set? Like what year?
I have no idea.
1989.
Oh my goodness.
So if plumbers were dealing with contracts from 1989, if the defense industry were dealing with contracts from 1989, if literally any other profession were having to deal in 1989 dollars, there'd be riots in the street. Like this would not stand.
Mm-hmm.
And what's so disheartening is that if you read the Medicare physician fee schedule final rule, so on their website, they quote, say, the 2025 physician fee schedule final rule is one of the several final rules that reflect a broader administration-wide strategy to create a more equitable healthcare system that results in better accessibility, quality, affordability, empowerment, and innovation for all Medicare beneficiaries. So Medicare believes that it's innovative to pay us rates that decline every single year, and they believe that it's equitable to let us deal with 1989 set contract limits. It's just that the disconnect between what patients are experiencing, what physicians are experiencing, and what Medicare is experiencing is so vast that all of us have to raise our voices and share with them that they got it wrong again.
Yeah. And you also mentioned access. And right, we talked about how if you don't pay physicians, there's not going to be any of them left. In my healthcare system, for instance, I think primary care doctors are not taking any new patients because there's just aren't any of them. Rheumatology, we used to have our first available appointment. It used to take like 3 to 6 months. So huge issues with the workforce and how these Medicare reimbursements directly affect the workforce and impact the workforce shortage that we see in rheumatology.
Well, and it's interesting because we are under this system under the guise of capitalism, but we keep physicians under the boot of a staunchly non-capitalist system. We have put such controls and such limitations on the earnings, on the payments. It's decidedly, absolutely not capitalist. And not to say that healthcare should or should not be a capitalist system. Obviously, there are arguments either way, but America's healthcare system is designed the way that it is because America has decided that it should be, but then created a system that is not. So physicians are really caught in this terrible place where they can neither compete in an open market because of the way that Medicare is operating and influencing everything else in the market, but also are not in a more secure position in the way that a single payer system is set up, where they're just clocking into work, receiving a paycheck, getting benefits, and then having the security of that sort of system. So there's this terrible kind of in between. We talk about this all the time in our more political events where people on the far right are like, well, isn't the worst case scenario a single payer system? And it's like, well, there are benefits there where at least there's this security that a lot of our physicians would, I think, really love to have, where they could just get a paycheck, their benefits, and never have to worry about who's going to buy their practice, what is the reimbursement going to be next year? How long will it take them to get their payment from Medicare that they've been waiting on forever? How many staff are they going to need to pay for prior authorizations? All of those sorts of things. And then on the other side, the system in the 80s or the 90s, where the person they bought their practice from or who was doing this before them maybe had an incredibly lucrative career. That generation of people and the legislators who were controlling the rules that they operated under cannot understand how these aren't the Porsche driving, doctors of their youth. And so I just think that there's got to be a readjustment of understanding what today's physicians are dealing with, what in 2024 physicians are actually operating under, and readjusting and having to figure out, because like we're pointing out, the patients are the ones that are going to suffer because physicians do not want to be operating in the system as it is currently existing.
Yeah, and we're having huge changes. And in my hospital, there's all these conglomerates that are being set up to sort of try to fight or try to cope with these lower payments, right? So making these, large industrial size healthcare systems to try to have a voice or try to lower costs to sort of put up with these challenges for physician payments.
And I'm also an employed physician. And so, the solution that I am told that when the reimbursement drops, you just see more patients. And the patients will tell you that a 10-minute visit with a rheumatologist is not going to cut it. And so it's dissatisfying for patients because they don't get their complex healthcare needs met in an adequate amount of time. It's dissatisfying for physicians because we know that every patient encounter generates a lot of downstream work. And, you just get kind of compassion fatigue after a while. It's really hard to give your whole self, your whole empathetic self to a human when you have to do it 25 times in a day. And it's just really terrible system to be in when that's the solution. On the other hand, what we're seeing is there are practices in our area that are charging a concierge fee. And so the people who can't afford it are now looking for new rheumatologists. So when you do have a capitalist system, like Lennie said, in medicine, then that means that physicians have entirely opted out of the insurance game and they're just going to accept cash for their services. But the people who can afford that are not the people who are having problems with access to healthcare, right? So this cut in the Medicare physician fee schedule continues to drive the inequity that we see. It increases this chasm between the haves and the have-nots that we're seeing, and the wealth gap just continues to be perpetuated by these draconian policies.
Yeah, such good points. So it sounds like Medicare reimbursement, PBMs, and all these issues are a huge part of what the ACR is advocating for. Are there other big topics like this that the ACR is working on?
Sure. So right now we're in the lame duck session of the 118th Congress, which means we're at the very end of a 2-year Congress. Every bill that has been introduced this Congress will cease to exist at midnight on December 31st.
Wow.
And we will start with a clean slate on January 31st with the new Congress, the new administration. So our scope really focuses at the end of a Congress because obviously we have about 20 business days with this Congress left to get anything done. And one of the things that this Congress has to do is fund the government. So they have that focus with the results of the election, which is one of the things we're going to focus on in the Convergence session. We're really going to go through the election results and what that means for the next Congress. But one of the things that it means for the remainder of this Congress is the Republicans, with their control of all of the branches of government, are probably going to push the budgeting decisions onto the next Congress. They're going to want to wait until they have their administration in place, their control of the Senate, and their control of the House to make big budgeting choices. So we're probably going to see a continuing resolution. My guess is until March. So the budgeting process might not take that long. So we might be able to get through that quickly. And then in the lame duck, we have 2 big priorities. One is avoiding these Medicare cuts. Like I said, our priorities are really dictated by timeline. These Medicare cuts, because they would be implemented December 31st at midnight. So January 1st would be the beginning of the 2025 fee schedule, which would include these cuts. And then the other thing that has a timeline on it is the expansion of telemedicine that we saw in relation to the COVID-19 pandemic that allowed people to access their physicians via Zoom, via any video platform or any audio-visual platform, but also via phone calls, and that Medicare would reimburse for that, and then also leading private payers to reimburse for that as well. Those expansions are all expiring at the end of this year. So while we have other priorities that were introduced this year, we have PBM bills that we were excited about, prior authorization reform bills that we were excited about, and we would love to see those get attached to packages and move this year. Our priorities are really the ones that are going to cause chaos on the calendar. The other things can be reintroduced in the next Congress. So we are really looking for the telemedicine extensions. Telemedicine, less than, I believe, 3% of the rheumatologists that were our members reported using telemedicine in their practice before COVID-19. And I believe, based on our kind of anecdotal data, that we are pretty average, which would say if we're around pretty average, that means between 70 and 74% of our members are now using telemedicine as a way to connect with their patients.
Wow.
So that loss would be incredibly impactful to both our members and our patients. One of the things that we're seeing is this isn't just about convenience. This isn't just about efficiency. This is a way to work around things like the impact of global warming. Christina was reporting to us that when the fires were rolling through California, it was a way for her to not lose the schedule with her patients, that she was able to stick to see her patients via telemedicine, even when fire made her unable to get into the office. So we are definitely working really hard. We're encouraged. Vice President-elect J.D. Vance introduced 2 telemedicine expansion bills in the Senate. So we know that the administration's also with us on supporting telemedicine. So we have no reason to believe that the recently elected administration or leadership would be against continuing those telemedicine access issues. So we're hoping that gets done before the end of the year as well.
So that means that if it doesn't get approved, that telemedicine is no longer going to be reimbursed, or that it won't be reimbursed at parity?
It would no longer be. It would just go back. The rules would go back to pre-COVID-19. So telemedicine would only be reimbursed if you are in a rural area as defined by HRSA. So we would have to introduce legislation essentially to create new rules to allow people who are not in a rural area access to telemedicine.
Wow.
We'd have to start over, essentially.
That would be a huge loss to healthcare, right? And to
Absolutely.
patients. So many patients, that I see in Western Massachusetts or even in other states have, such difficulties making it to my clinic that, offering these virtual visits they don't have to miss work, right? They don't have to get their kids out of school. It's so much more convenient, and still we're able to do a lot of the things that we would have done in the clinic. I can't imagine going back to the pre-Zoom era of healthcare.
Yeah.
And
That would be awful.
again, I would say that this is also a health equity issue because I serve a low income population in one of my practices. And these are people who don't get sick days. These are people who barely have enough gas money to get to work or to get their kids to where they need to be. And so it's been a huge relief for a lot of my patients to be able to do a video visit if they're feeling stable, if they're feeling well, if there's nothing on physical exam that I necessarily have to put my hands on. It's been such a blessing for those families. And my Medicare population as well. I have a lot of Medicare patients who are surviving on Social Security checks. And when gas prices were really high, they were almost brought to tears telling me, thank you so much for letting me do a video. Like I didn't know how I was going to afford the gas to come in. So this is crucial to help continuing to take care of the most vulnerable among us.
Also, while it feels like we're coming down to the wire, it's not surprising to me that this had to wait until after the election. Energy and Commerce did do a markup, and Energy and Commerce is the committee of jurisdiction in the House over this topic, did do a markup before the recess for a 2-year extension of these telemedicine expansions. The holdup really has been the cost. The Congressional Budget Office scored that 2-year extension at $2 billion a year based on the increased use of Medicare services. We would like to see a longer extension, but I think that 2-year extension, what it's going to do is allow the CBO, the Congressional Budget Office, to have more data to see what we think we're going to see, which is mitigating data, which is less emergency room visits.
Right.
Like they're currently just estimating the use of the services as opposed to the offset, which is people not using other Medicare services. So we think that 2-year extension will then lend itself to a longer extension. But really, what we're talking about is when you're talking about something that's $2 billion, no one in either party needs to have their opponent being able to drill them for having added $2 billion to the deficit. So I think we knew that this was going to have to wait until after the election. And today is the first day that Congress is back. Well, or yesterday was the first day that Congress is back. So November 12th, 11th, and 12th is really when Congress returned to DC and is able to really start talking about this package in truth after the election. So it feels like it's down to the wire. We kind of knew that they would really start talking about this in earnest. And Energy and Commerce doing that markup before recess lays the groundwork for what we assume will be a package that is the basis for a bill to go through during this lame duck session. So they've done everything they need to do to signal to us that they plan to do this before the end of the year.
I hope so. Yeah, I mean, this is something that I think everybody, patients, physicians, everybody seems to be in agreement that it's a wonderful thing and one of the few great things that came out of the pandemic is this ability to sort of meet patients where they're at virtually and still provide care. Hopefully we can keep it going.
Absolutely.
So we've spoken that the Biden administration is going to be done and we have the Trump administration coming in 2025. Do we have any ideas about how healthcare may or may not change with the new administration?
Sure. So we have a new administration, but he's not an unknown entity. We've had a Trump administration before. As far as we can tell, he's not bringing back in any of the previous people that he worked with. So slowly but surely trickling in are some appointments, which is interesting politically for me, since my primary position is lobbying Congress. And so far, his picks have been from the Senate and the House, which is especially interesting because when you're picking Stefanik for ambassador to the UN, she is a New York Republican in a solidly Republican district, but previously a purple district, not in the not so recent past. And that's going to require a special election for that district. So when you're talking about a House that may be Republican by 4 seats, 5 seats, and a special election when currently the feedback that we're getting is there's a lot of people in America that feel like maybe we swung too far in the most recent election, and in special elections, a very small amount of people show up and they tend to be very passionate. If I'm the House Speaker, I'm concerned if the president's picking my people.
Interesting.
For these positions. So I've been watching those with a lot of interest. So yeah, it's been very interesting. Like we've been talking about, in my circles, we've been talking a lot about this. We were talking about this before the election, and then it came to pass. Every incumbent or governing party facing election in a developed country this year lost vote share for the first time since this data was recorded in 1905. So essentially the first time in the history of democracy since suffrage began arguably in 1894. So every single governing party that was in charge of an economy after the pandemic lost. So while America feels like this was a very American election, and obviously we had Joe Biden, who is our current president, and we had Trump, who has been our president before, the trend that we saw in the presidential election was the trend we saw across the globe. But what we're seeing in American politics is also just in the midst of the voting trends that we saw are a true realignment along the lines of race, along the lines of education, along the lines of income. neither of the parties voted in the way that they have traditionally. And so I think it's a
Right.
really interesting time for both parties to revisit and not be beholden to all of the things that they have felt like they had to always stand with for and represent
Hmm.
due to the voting bloc that has been with them, because those voting blocs aren't necessarily with them. So it's going to be a really interesting term to see how everyone acts in kind of the new world order. But Trump has also never been a bellwether for Republicans. I think it's very interesting how much split ticket voting we saw in all of the states where there was an abortion or access to care, like access to women's medical care issue on the ballot. We saw split ticket voting for that issue, but also for the Republican president. We saw a lot of split ticket voting for Democratic senators and a Republican president,
Hmm.
but also for abortion access. Even in the state of Florida, where the government used his platform to lobby against the ballot initiative, 57% of people voted to protect and to put in place access to women's care. And, as a healthcare organization, that is something that is, of course, always of interest to us, because we saw methotrexate limitations and a lot of concerning things after Dobbs that we have been always, access to care and making sure to not stand between the doctor-patient relationship is certainly something that we've been monitoring since Dobbs, because that state to state has been an issue for a lot of our members, especially as new liabilities come up. Like we've mentioned, the new administration seems to be signaling that they're with us on PBM reform for the pharmacy benefit managers, which is certainly helpful. But there are some things that are somewhat concerning. This Congress, there was a somewhat seemingly retributive introduction of a National Institutes of Health reform package from Kathy McMorris Rogers that seemed to be in reaction to the National Institutes of Health handling of the COVID-19, everything, Fauci's response, et cetera. And a lot of people in healthcare didn't take it super seriously because Biden was president, and obviously the National Institutes of Health would never be reorganized in this way. That didn't make a lot of sense. In fact, I was at a political fundraiser where we made the joke that they were suggesting that we reorganize some of the departments into the head, because it was like some of the specialties, literally, it seemed like they literally just took everything above the shoulders and were like, this will now be a department. Yeah, exactly. We were laughing. We were like, that seems crazy. But now there has been some signaling from the new administration that they think that reorganization plan might be something they pick back up. So there are things like that where we don't know exactly where we're going with a lot of these things. But it's also a new world order in that we're definitely going to get a Senate majority leader. We have a race between Senators Thune and Cornyn, and Rick Scott has also put his name in the hat. That one's going to be very interesting, because while Trump rules with an iron fist over his party, and people tend to do what he says because he punishes and he will let it be known. But that vote is secret ballot. And so when you vote for a Senate majority leader, no one knows who voted for whom. So while Mitch McConnell's era has ended, we don't know who will be next, and we won't know who votes for who will be next. So regardless, it's going to be a new era in the Senate, and the filibuster rules are still in place. So you still need 60 votes to pass anything in the Senate, unless it is germane to tax, spending, and debt limit legislation. So basically anything non-financial still requires 60 votes, and things are still slim margins over there. The House margin, like we've talked about, is razor thin. Mike Johnson will stay the speaker, but the margins are razor thin. And if Trump continues to appoint Republicans from the House, and we're doing special elections, things are going to be interesting over there. And then the one other thing that I wanted to point out is the administration is additionally operating under a shift in rules with the repeal of Chevron deference under a Supreme Court decision called Loper. which is a substantial curtailment of the authority of the executive branch, as courts are no longer allowed to defer to an agency's interpretation of statute. So it used to be that if an agency, so the EPA, the HHS, if they put a rule in place and that rule was challenged, the court could defer to the agency's interpretation of the statute.
Okay.
And that rule had been in place for 40 years and has now been repealed. So basically, a law or a piece of legislation has to specifically empower the administration or the agency to make a rule in order for that rule to stand up in court. So this administration is also going to be operating with a lot less leeway than administrations for the last 40 years. So for those who went to the ballot box hoping for a new slate, we're getting it. There was a purge, essentially. We're going to get a new Senate leadership. There is new rules and a new administration. The House, while maintaining their speaker, has had a ton of turnover. I know a lot of people are feeling a lot of ways coming out of the election, but we are certainly also in the midst of a global trend that has caught everybody in the wake of the economy's post-pandemic. So the one thing that is consistent is the ACR will continue to represent the interests of the ACR and the ARP, and we have educated every new Congress on our priorities and the issues facing our members and our patients, and that won't change. And we will get to know the people that are brought in both the administration and Congress and make sure that we work with them as effectively as we can to get everything that we can get done policy-wise, to make sure that the doctor-patient relationship and that the lives of rheumatologists can move forward as effectively as possible in the next 2 and 4 and 6 years as the terms are laid out.
And we are so lucky in the American College of Rheumatology to have Lennie's expertise and the rest of the staff who fight on our behalf every single day without us ever knowing it. But the good thing is that if you are an ACR member and you want more one-on-one time with Lennie or Joseph or Meredith or any of our wonderful staff, they actually have open office hours. So you can go to the advocacy landing page on rheumatology.org and sign up for a block of time to get office hours with our advocacy staff.
Amazing.
Yeah. And we'll talk about issues with you. We'll talk about elections with you. We'll talk about state issues. We'll talk about insurance payer issues. We have a regulatory expert on staff. Advocacy is part of your membership benefit. So anything that is troubling you or you have questions about, we want to make sure we have time to address with you.
Great. Can we talk just a little bit about some of the arms of the ACR? For instance, Christina, I believe you're the chair of the Government Affairs Committee. So what is that committee sort of, what is its purpose? And Lennie, if you could talk a little bit about RheumPAC and how some of those things differ.
Yeah. So the Government Affairs Committee is the cartography branch of the advocacy wing of the American College of Rheumatology. So we set down the guide for what we want to focus on. So the panel of experts are the Government Affairs Committee members, and they tell us, this is what I'm seeing in my practice. This is what my patients are coming to me with. This is the challenge I'm having in research funding. These are all the problems that I'm encountering. And so we have on our committee private practice folks, we have academic folks, we have employed physicians, we have NPs, we have PAs, we have pharmacists, we have office managers, we have a fellow representative, we have people who are retired, we have people who work for industry, we have people who work for Medicare. Nobody is off limits to this committee, and we try to make it as diverse as possible. Not only career setting, but age, geography, gender, ethnicity. We do our best to try to take a true sample of the American College of Rheumatology membership so that we could be sure that we are setting those guardrails with things that are relevant to the membership.
And then Lennie, for RheumPAC, so that's the, you mentioned a little bit before that, the ACR is not allowed to use membership fees to lobby Congress. So that's where RheumPAC plays a role. Is that right?
Yeah, Absolutely. As Christina mentioned, the way that we pick these committees, we make sure that there's a representative sample of the membership. And while GAC is in charge of all of our legislative priorities and all the things that we are working on and prioritizing, and those things that we take to the Hill and lobby, one of the really important aspects of that is being able to support legislators and champions, not just in formal Hill meetings, but also in their campaign settings. These settings, so like before I was at the ACR, I worked for federal campaigns and I was a Hill staffer. And one of the things that you learn is in a Hill meeting is 30 minutes of your day. You like a physician, you fit in as many of them as you can because you're trying to appease as many constituents as you can, because that's your job as a representative of your boss. You're just trying to get face time with as many constituents as possible, and you're not absorbing the information because that's not your job. Your job is to make sure the constituent feels seen. It's not to learn what they're there to talk to you about. Whereas on the fundraising side, you are trying to raise as much money as possible to mount a campaign, because unfortunately in the American system, it costs millions of dollars to run for Congress. And on the House side, you have to do it every 2 years. And on the Senate side, you have to do it every 6 years. But the best way to raise money, while local events are great and they help you get to know your constituents, in DC, you do long lunches, you do long dinners, and we try to target Medicare or healthcare specific events. So we are in a group with a lot of medical specialties called MADPAC, the Medical and Dental Political Action Committees, where we sit down with legislators and talk about healthcare specific issues and use our PAC money to support our champions that have introduced things like PBM reform, like prior authorization reform, like Medicare reimbursement mitigation or Medicare reimbursement cut mitigation. So, you might see us maxing out, which means giving $10,000 to someone, which means they are with us on every issue. Or you might see us giving $1,000 to someone, which means basically we wanted to go to an event with them because we really needed to talk to them about this one issue, but they're not a champion of ours yet. So like we're not fighting for them to return in the next Congress with everything we have. But that PAC money it's not just access so that we can have these more in-depth conversations that we can't have at the Hill. It's also, like we just saw in this election, these elections can be bloodbaths. You can lose people who have been in Congress since the 70s, people who you thought were so safe. And it costs a lot of money for them. And so any way we can help them to return so that they can keep fighting. One of the things that I think is important for people to understand is people talk about term limits, et cetera. And the ACR has no stance one way or another on term limits. But one of the things both parties is suffering from is a real problem finding candidates who want to run for Congress. And so we need to be preserving people who know about our issues, care about our issues, and are fighting for our issues. So anything we can do to help them get reelected, we really want to be doing. But like you said, we cannot use ACR funds for that. So RheumPAC is the only way to do it. So RHEUMPAC.org is the political arm of the ACR. It is a limited fundraising branch. So whereas a charity can fundraise from literally anybody, a political action committee can only fundraise from current members of the ACR and ARP. So you are our only possible contributors. We can't go out and get money from other people.
Got it.
So we appreciate anyone's support for the work that we do. And if you have any questions, Paige Colston on our staff is our PAC manager, and she does great work and is available anytime for anyone with questions. And Christina is an avid supporter of our PAC. And so as a supporter, do you have anything you want to add?
Yeah. So I have given continuously since I was a fellow. When I was a fellow, I think I invested $20 a year. So you don't have to invest $5,000 to be a PAC investor. You can give any amount of money and it is very welcome. So one of the things that's important to understand is that it's percentage of membership just as much as it is actual dollars. Because if we only have 2% of our membership investing in the PAC, then the PAC looks like a fringe group within the ACR and that it doesn't represent all of our members. When in fact, we are, using those funds to represent every single ACR and ARP member and all of their patients as well. The other thing is I am one of the biggest advocates for getting money out of politics. I would love to see caps on fundraising for elected officials. I would love to have, no money involved. I would love to shorten the election cycle so that we don't need so many
Yes, please.
advertisements.
Oh my
I
goodness.
definitely want all of those things. But again, we have to live in the world that we're in and not the world that we want to be in. And unfortunately, in the world that we're in, money actually is speech and it is access. And it's a way for us to get the right ears to listen to the messages that we have. So even if you feel icky about all of the money that's in politics, please don't feel icky about investing in your own future and your own access to those political leaders.
Yeah.
I also wanted to point out we have a card, like a scorecard that we use that is nonpartisan that ranks each legislator based on what they've supported related to our policy priorities and their placement on committees of jurisdiction. They are out of the running if they are too far to the left, too far to the right, if they're a part of a caucus for something that the ACR opposes staunchly. The PAC board took a position on, has taken positions on things in the wake of Dobbs, has taken a position on things in the wake of January 6th. So the PAC board is very reactive or the PAC committee is very reactive to the feelings of the membership and what's going on in Congress. And we stay nonpartisan and we have this scorecard to make sure that we are assessing people based on their actions in Congress. And basically anybody who is, if you've seen their name on a cryon on the news, they're basically already out of the running to receive PAC support from us. It's those diligent lawmakers that are on committees of jurisdiction behind the scenes doing healthcare work that we're supporting. So we don't write checks to people who are in leadership. We don't write checks to any prolific tweeters. These are the people that are on Energy and Commerce, on Ways and Means, on Senate Help and Senate Finance that are doing healthcare policy work. And that scorecard is open to any member who wants to review it. But this is a really good way for you to act on your personal politics and your personal time and volunteer for any way that makes you feel like you're doing what you need to do for your country, that makes you as a citizen feel good, while knowing that your professional interests are being covered by the ACR and by RheumPAC.
Amazing.
Because that's really what we're doing.
Yeah, amazing. And we'll have links to RheumPAC, Advocacy Day, the drop-in with Lennie, all from our show notes. So for listeners interested in learning more and getting involved in advocacy and with the ACR and with RheumPAC, we'll have all those links in the show notes. Lennie and Christina, thank you so much for your time. It is so timely that we're discussing these issues. And I really appreciate all the work that you do on behalf of the ACR, on behalf of rheumatologists and APPs and our patients. Thanks for your efforts. And we'll touch again next year.
Thank you
so much for having us.
As you've just heard, there are several issues that can potentially have huge impacts in how we care for patients with rheumatic diseases. From Medicare reimbursement challenges to the need for PBM reform and telemedicine expansions, these legislative efforts are vital to the future of rheumatology and for equitable patient care. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find show notes for this and all the other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep advocating for better healthcare policies. And of course, stay healthy.